Victor Guajardo is a healthcare innovator who designs medical plans that connect employers directly with healthcare providers, eliminating traditional insurance middlemen and reducing costs while improving access to care. With a background in mathematics and a passion for sustainable healthcare, Victor creates win-win scenarios where employers save money, employees receive barrier-free care, and providers get paid promptly without administrative headaches. His mission is to preserve the healthcare ecosystem by keeping physicians independent and making quality care accessible to everyone. Victor, help us understand what you do.
Yes, so you kind of just stole the thunder. That's exactly what I do. I typically work with self-insured plan sponsors, so groups with 100 or more employees, but I can work with any size. And I remove the middlemen, typically the network carriers. So think Blue Cross, United, Cigna, Aetna. The way I do that is with direct agreements, cash pay model systems, and different forms of pricing, whether it be based on a percentage of Medicare or based off of usual and customary for that specific market. It- Additionally, I will work with the stop loss carriers and underwrite the stop loss separately, the medical and pharmacy separately, and direct contract for importation on some of the medications, or get a direct contract between a GPO and an employer. Do my best to bypass PBMs in any way possible. If I am working with a PBM, really locking down the arrangements and the contract between the PBM and the plan sponsor. A PBM is a pharmacy benefits manager. No matter what medical plan you're on, your medical plan does have a separate PBM arm. You just don't see it. In the self-funded world. You do see it because you're doing your best to separate the different vendors, so that way you cut out a lot of the games that they can play with earning their revenue. So that's kind of in a nutshell what this looks like. A TPA is a third-party administrator. You can just think of
Ah,
this entity as the entity that's responsible for paying out claims on your group plan's behalf. So let's say you have an employer-sponsored health insurance through Blue Cross that's fully insured with your employer. That means that your employer is using Blue Cross as not only a network, but also as the claims administrator and adjudicator to pay all of their claims out according to the Blue Cross contracts. And your employer and yourself are only responsible for paying the premium, but you're not responsible for any of the losses that are incurred. So in that arrangement, it is the insurance carrier taking on full risk for those medical claims. And in the self-insured world, you can separate them and you can rent the Blue Cross network and use a third-party administrator who's independent of the carrier to pay out claims on your behalf according to carrier contracts. Or when you reach different levels, you can use cash-based contracts, or you can use reference-based pricing amounts, which are just pricing amounts that are essentially priced against Medicare, plus an additional amount of revenue for the physician's office or provider or hospital system. But at the end of the day, all health plans are built the same. They all have a pharmacy benefits manager, which you may or may not see, a third-party administrator, and a quote-unquote network, depending on the plan design.
Victor,
And
who's your target
uh-huh.
audience?
It is really physicians, hospital
Ah,
systems. It's anybody who is involved in providing care to individuals. So anybody in the healthcare continuum, really getting them to understand alternative payment models, direct pay, direct contracts between them and the employer, them with cash pay, them with a different type of reference-based pricing, to understand how a group or a plan sponsor can get rid of or remove the revenue cycle altogether. And it's also employers. So it's connecting the two, working with employers to understand, hey, there's a different way than just getting your Blue Cross or your United or your Cigna and letting them run your plan and your costs go up each and every single year. doing it a different way can help lower your plan costs and improve your population health.
And how would you define, Victor, your company's role in this? Because what it sounds like to me is, and I think Don was saying the other day, you kind of match the employer to the physician or physician group. Is that right?
Yes, to a certain extent. So,
Mm,
my specialty is really pairing the employer with local direct primary care physicians, and setting them up on a risk-based arrangement or a subscription fee. So, typically, I will connect an employer with a local primary care group, and for let's say $80 a month or $90 a month for the entire population, that primary care group will deliver unlimited services to the employee population. And we've really seen that reduce the total claims that
mm,
the group experiences. And so it's really plugging in arrangements that improve population health, which lower the claims experience as a small part of designing these health plans.
mm,
And I want to make sure, Victor, that you get your opportunity to ask for what you
mm-hmm.
need and offer
Yes.
what you can to the community if
Yeah.
you're ready to do that. And then we can have more questions later if you wish.
Yeah, so what I need is really for more physicians to, understand and be open to alternative payment models like payment arrangements, direct employer agreements, and their willingness to accept these alternative approaches to getting paid. It's an entire, healthcare community. If we preserve this access to care and we can make it more affordable for everybody. These cash payments are, they pay you same day. So it reduces your reliance on waiting 30 days, 60 days, 90 days from a carrier when you can get it directly from the employer group without any prior authorizations or whatever makes your job harder to perform. And also additionally from the community, really employers being open to breaking away from the traditional brokers who are just going to stick them in the same health plan that has increases every year rather than trying to get to the root cause of the premium increases.
Mm,
Um, what I can offer is expertise in building these sustainable healthcare arrangements, or just providing questions for you to ask to your broker to help them do something different for you. It's not really my intention to become your broker or your consultant or anything, but to help you understand what goes into building a health plan and how you can fight the continual increases and the unsustainability path that we're on.
mm. You know what I'm fascinated by is there's this level of complexity behind the scenes of healthcare that I don't know about everybody else on the call, but I was unaware of just how complex it is. And the value of somebody such as yourself, Victor, who understands the scope of it. I think that's really helpful in this network of HRC when we're talking about some of these complicated pieces. But then when you're working with those groups, your target audience groups, helping them, I would guess, better understand the structure and helping them to navigate a path that benefits both sides, the patients, three sides, the patients, the employer, and the physician group themselves.
Yes, 100%. So what I do for just at no profit to myself. I'm a patient advocate. So additionally, how I can help, our group is people dealing with excessive medical bills.
Mm,
I have expertise in charity care applications, bill reduction strategies. Typically I can get, five-figure bills down by about 90%
wow.
by
Wow.
utilizing IRS code 501R, or just repricing according to Medicare and having the person, providing verbiage that the individuals provide to the hospital systems that says, "Hey, I'm not going to pay you more than 150% or 200% of Medicare," and that alone probably will cut a five-figure bill down by 90% or more.
Sure, I'd like to hear a little bit more about your quality of care and your access to care. So, how do you ensure that somebody has the ability to get the best doctor, the best care, and the best quality?
Yeah, so that's actually my favorite part in all of this. So I currently use something called GAM Metrics, GAM. It was set up by Dr. Will Brunn, who was a student of Dr. Marty Macri. And what GAM Measures does is it takes all the CMS public data in addition to insurance data. It does look at clinical outcomes, and it is those physicians who are providing the good clinical outcomes who happen to be low cost as well, who are being listed on any of these health plans as saying, hey, if you visit them, it's no cost to you. So that is one of the ways we're doing it. If it's not that way, it's doing it with care navigators who are nurses, and the nurses are able to use the data as well to drive individuals towards physicians who have those good outcomes. I kind of refer to myself as building these billion-dollar jets that don't get used.
Oh,
A lot of the time they are plans designed with no cost sharing because my goal is to remove the barriers to access to care. By removing the barriers to access to care, you're getting the population healthier because people are getting seen and diseases are getting caught that much sooner, which means the plan is going to pay out less and avoid potential ER situations or potential chronic diseases. So being fiscally responsible just happens to align with keeping people healthy. And the ultimate goal is to keep people healthy. And your reward is not spending a lot of money on healthcare, which lowers premiums, and then everybody's happy.
Victor, you're just so knowledgeable in this area. I'm just continue to be amazed at how much you know about this and how little I know about it. So
mhm.
I appreciate that there's someone that really geeks out on this like you do.